My name is Amy Pierre, and I'm a senior clinical director at Flatiron Health and also a nurse practitioner at Memorial Sloan Kettering in the myeloma lymphoma division. And I want to talk a little bit about Multiple Myeloma Awareness Month and what it means to me as an advanced practitioner and also as a researcher. So, Multiple Myeloma Awareness Month, I find it as an opportunity to really shed light on a very complex and often misunderstood disease that disproportionately impacts certain populations in America. So, for example, African Americans are 2 to 3 times more likely to develop myeloma than any other race or ethnic group. And they also have higher mortality rates. And we do see myeloma affecting a lot of people who are older. So the average age of diagnosis is 69. So we're seeing certain populations more disproportionately affected. And as an advanced practitioner, it's a time to not only reflect sort of on the progress that we've made in improving survival rates and other things, but also to focus on addressing some of the inequities that we see at diagnosis and treatment. So it's really about raising awareness on early symptoms and advocating for timely diagnosis and educating patients and providers about evolving therapies. We've had a lot approved in the last decade. And it's deeply personal for me. I have family members who are affected by multiple myeloma. So being able to amplify the voices of patients who may not always be heard and ensuring that every patient, regardless of what their background is, has access to high quality evidence-based care. Some of the key research and patient education priorities that I see surrounding myeloma, speaking specifically on the patient education point first, is recognizing early symptoms. So, signs and symptoms of myeloma, the most common sign and symptom is bone pain, specifically back pain and fatigue. And, if you ask a crowd of people, who's experienced that symptom, most people are going to raise their hand, right? So the signs and symptoms are very insidious. And so it's important to educate patients on what signs and symptoms of myeloma might look like outside of that, particularly those who are at higher risk, right? So African Americans, we know, are higher risk. People who have first degree relatives with myeloma or a monoclonal gammopathy. Um, they need to understand what the early warning signs are, which could be the bone pain, the really excessive fatigue, and not like I take a nap and feel better, but more I'm having trouble getting through my day-to-day stuff without needing to lie down. Having frequent infections or an anemia, and they don't really understand where their anemia is coming from, or they run a chemistry panel and there's a really high total protein number. Everyone gets routine chemistry panels, but not everyone's looking at that high total protein number to see why it's elevated, if it's elevated. All those things can lead to an earlier diagnosis. And then a patient who's been diagnosed, understanding all the treatment options, right? So helping patients and families understand what treatment options are most specific and individualized for them and what makes sense for them, including the novel immunotherapies, so CAR T and bispecifics, and most importantly, clinical trials, what are available to them. And sort of just empowering self-advocacy, right? It's all about equipping patients with the knowledge to ask informed questions and engage actively in sort of shared decision making in their visits with their provider. And then, sort of from a research standpoint, I obviously am deeply passionate about health equity and health equity research, and I do a lot of analysis on real world data. So it's important to sort of understand how race, ethnicity, age, gender, socioeconomic status, geographic location, all the factors can affect time to diagnosis, time to treatment initiation, and how that affects long-term outcomes. So real world data and real world evidence can actually highlight some of those gaps in the care and inform more inclusive treatment approaches. And then I think if I'm thinking specifically about sort of novel testing, MRD, so minimal residual disease testing, and the search for biomarkers. So exploring minimal residual disease testing, or MRD as an endpoint, a surrogate endpoint for a functional cure, which would be amazing, and identifying biomarkers that predict response or relapse. We have a good idea of some of those. We have a lot of prognostic biomarkers, but we need more predictive biomarkers in myeloma, meaning an actual targetable thing that X drug, if you have that thing, X drug will work on it. So we have that with translocation 1114 and some of the BCL2 inhibitors, but we don't really have anything else outside that, where a lot of solid tumors do have a lot of sort of predictive biomarkers. And then sort of understanding optimal sequencing of some of these special drugs like CAR T and bispecifics and et cetera. And then thinking deeply more about inequities, I did have an abstract, a poster at ASH in 2024 on myeloma. And I was talking about FISH testing inequities, which is something everyone knows that you do at diagnosis and is very helpful at relapse to see sort of what clonal evolution has taken place and if there's been any acquired additional genetic mutations of the myeloma itself. We found that there was FISH testing inequities, lower rates of FISH testing among patients who lived in neighborhoods with sort of higher rates of limited English proficiency. So we were looking at how specific social determinants of health factors affected access to FISH testing. And we also found lower rates of FISH testing in neighborhoods that had low rates of vehicle ownership. So this tells us that we really need efforts aimed at addressing social determinants of health factors, particularly language, particularly transportation barriers. All these should be prioritized to advance equity in FISH testing. More so, given the prerequisite of FISH testing to determining eligibility for biomarker-driven trials, findings from that study suggest there's potential opportunities for increasing equity in clinical trial participation through focus on SDOH. All in all, this really results in sort of what we see as missed opportunities for risk stratification for patients and missed opportunities for appropriate treatment selection. And other barriers that we can see is limited access to specialty care, right? So patients who live in rural areas or underserved areas, they lack access to specialists and may just present with advanced diagnosis because of that. Implicit bias, misconceptions about patients. There's a lot of studies that show that implicit bias can contribute to delayed referrals. It can contribute to underutilization of novel therapies in marginalized communities. And then also there's financial and social barriers, right? Like I talked about the transportation issues. There could be caregiver responsibilities that a patient has to maintain. Insurance coverage or minimal insurance coverage, all that can affect timely treatment and timely follow-up. And what can nurses and advanced practitioners do? So, advocate for early testing and standardized protocols, ensuring that all newly patients receive standard of care, including FISH testing, regardless of where they come from or who they are. There should be community outreach and education. So, engaging in outreach efforts to educate communities about myeloma risk factors, symptoms, the importance of clinical trial participation, and addressing implicit bias through education, right? Encouraging ongoing education on health inequities, incorporating, culturally appropriate care into practice, and making sure providers are taking their own implicit bias tests so they can understand sort of what blinders that they have.